Hi, I'm Matthew Bunty. I'm the Director of Vascular Medicine at St. Luke's Mid-America Heart Institute in Kansas City, Missouri. I'm pleased to present Time to Redefine Critical Limb Ischemia. I have no disclosure. Wound healing is proportional to oxygen tension, and fibroblast function and oxidative immune function necessary for wound healing are inhibited by hypoxia. By definition, critical limb ischemia is the presence of rest pain or tissue loss more than 2 weeks, and it is defined by physiologic vascular testing, including an ankle brachial index, toe systolic pressure, or transcutaneous oximetry of certain threshold levels. For ischemic rest pain, that means an ankle systolic pressure less than 50 or toe systolic pressure or TCPO2 less than 30. For ischemic ulcers or gangrene, the threshold values are somewhat higher. While various schemes for classifying CLI have been used over the years, the Rutherford-Becker classification, originally proposed in 1986 and again revised in 1997, is probably the most frequent scheme, which I'm sure most of our audience is familiar. Central then to our guidelines for assessing critical limb ischemia is physiologic testing, starting with the ABI. Although there are limitations to the ABI, the guidelines also provide guidance with forefoot perfusion or local skin perfusion as necessary next steps for assessing a foot ulcer. And physiologic testing has some utility, as an ABI increase greater than 0.23 or a toe brachial index greater than 0.21 tends to be associated with improved outcomes. The limitations of ABI are well known, however, and the test does not correlate well with below knee disease. Our group showed that the ABI had an inverse relationship with the number of runoff vessels among patients with critical limb ischemia, and these findings were corroborated looking at the IMPACT DEEP randomized controlled trial data, where only 6% of those with critical limb ischemia had a severely reduced ABI, and fully 29% with critical limb ischemia and abnormal toe systolic pressure had a normal ABI. Medial artery calcinosis is largely to blame and is a major challenge to treating CLI. MAC is strongly associated with diabetes, end-stage renal disease, and leads to misleading diagnostic testing and specifically poorly compressible or non-compressible arteries. And there are also unique therapeutic challenges related to MAC. And in fact, non-compressible ABIs are a distractor when dealing with the critical limb population. Poorly compressible arteries are no more associated with limb revascularization than reference ABI levels, whereas they are more strongly associated with amputation. In a large registry analysis, the heterogeneous use of ABI has been exposed. This study was nicely done and looked at 47 sites in Michigan offering CLI care, including sites that offered peripheral vascular intervention and surgical revascularization. In over 5,000 patients, only 14% of patients receiving endovascular treatment and 27% of those receiving surgical revascularization had severely reduced ABIs. What's more striking is that only 44% of patients receiving revascularization had pre-procedure physiologic testing, and only 20% had toe systolic or toe brachial index testing available. And I think these studies highlight the limitations of physiologic vascular testing. Therefore, there is a troubled marriage between ABI and the diabetic foot, and this requires us to think about how we define this condition, particularly as the rate of total diabetes has really skyrocketed in our population in recent years. And in fact, looking back at the time since critical limb ischemia was originally defined in 1981, the prevalence of diabetes in our population has exploded and is now up 3 times. Therefore, the phenotype of critical limb ischemia is changing and is no longer just simply a painful rubrous ischemic foot, but there are other considerations, sometimes ischemia being a rather minor one relative to other issues of infection and offloading for neurotrophic ulcers. The wound, ischemia, and foot infection then was an answer to this problem, wherein threatened limb was graded incorporating wound severity and foot infection in addition to ischemia. This grading scale has been shown to correlate well with outcomes including freedom from amputation, and has prompted further discussion about redefining critical limb ischemia entirely. In 2018, the European Society of Cardiology and the European Society for Vascular Surgery published a statement proposing a new term of chronic limb-threatening ischemia. The objectives for defining CLTI were to expose the incidence of ulcers caused by neuropathy has greatly increased as associated with the prevalence of diabetes rising. And apart from ischemia, infection also poses a significant risk for major amputation, not well accounted for in current threshold values of perfusion alone. In some patients meeting the definition of CLI with gangrene or tissue loss or severe limb ischemia can avoid amputation with wound care and offloading and other conservative measures. So looking ahead, CLTI does seem to offer a continuum of ischemia without a threshold value of perfusion as originally defined, and Wi-Fi is relevant to contemporary patients that are increasingly diabetic. Multidisciplinary limb preservation care must be standardized, however, and perfusion assessment will enhance reperfusion strategy. And I like this figure published in a white paper showing the varied aspects of wound care beyond just ischemia evaluation and treatment, which I think goes to these multidisciplinary standards of care. Multimodality vascular imaging is also improving quickly, and we now have, in addition to physiologic testing, which has underpinned the evaluation of limb ischemics, tissue perfusion assessment and real-time perfusion that we can use in the cath labs or operating room, as well as enhanced anatomic imaging that overcomes some of the previous limitations. In conclusion, the CLI population as originally described has fundamentally changed. Lower extremity wounds require threshold oxygen levels along with attention to infection offloading and good wound care to achieve limb salvage. In universal definitions, treatment standards and coordinated comprehensive limb salvage are needed to ensure optimal outcomes. Thank you.